Okay. So our three presenters today will share, just a minute, we'll share, sorry. Our three presenters today will share how parent partners and different peer support programs supported organizations to enhance client satisfaction and baby-friendly best practices. Our first speaker will be Charlotte Maloney of the BCC Parent Partners, and she will introduce herself. So I need to stop sharing. And Charlotte, if you're able to share your screen.
All right. Is that okay for everyone?
Perfect. Looks good.
Great. So hi, everyone. I'm Charlotte. I'm based in Ottawa, and I've been involved as a parent partner for almost 9 years now, since shortly after my oldest child was born. So I currently chair a regional family advisory committee. I also sit on a quality improvement committee of the obstetrical unit at a local hospital. And I sit on a regional breastfeeding promotion committee as a family representative. So really involved in perinatal health as a parent partner. So now I've joined the Breastfeeding Committee for Canada's collaborative project as a parent partner coach mentor. So I'm able to work with organizations across the country and helping them to really integrate parent partners into their BFI work, which is my topic for my presentation today. So one of the International Association for Public Participation core values, I find that this really speaks to the importance of including parent partners in your BFI work. So its public engagement is premised on the belief that everyone has the right to be involved in decisions that will affect their life. So, you know, I think perinatal care is something that will definitely have huge effect on someone's life. So having parent partners involved in those decisions is really important. So if we look at patient and family-centered care, having a parent partner involved in your BFI work really speaks to two of the core concepts of PFCC. So that's participation and collaboration. So participation is patients and families are encouraged and supported in participating in care and decision-making at the level they choose. So, you know, this can be having a parent partner on your BFI committee. This can be reaching out to a wider group to get more feedback. And then in terms of collaboration, it's really about collaborating in policy and program development, implementation and evaluation, facility design, professional education, research, as well as the delivery of care. So a huge range of topics that a parent partner can be involved in. It doesn't just have to be, you know, reviewing documents or providing feedback on existing policies. So what can the role look like? So the parent partner could attend all of the BFI committee meetings. They can review and provide feedback on documents, policies, and procedures that are already existing and have already been created by your organization. They can share stories from other families that they hear in the community. So they have their perspective, but they also can be that link and that bridge to other families in the community and bringing their stories in as well. They can participate in planning improvement activities and collaborating on the development of documents, especially those that are patient or family facing. So again, it's great to get that feedback on existing documents, but really having a parent partner from the beginning provide their input in the creation has a lot more benefit than just that retroactive feedback. So in terms of what the organization can provide, so actively engaging the parent partner in BFI meetings. So this could look like having a standing item on your meeting agenda for the parent partner to, you know, share anything and give any feedback. It can be a bit intimidating for the parent partner to, you know, suddenly feel like they're comfortable jumping in at any moment. So really giving them that opportunity to share and making them actively engaged in the BFI work. Always explain any acronyms and medical terminology. This one was a huge one for me. I don't have a medical background, and so when this is your job and you're in it every day, it's very easy to just slip into saying these acronyms and the different terminology. So it's really, really important to make sure that either you explain it the first time or give the parent partner the opportunity to ask, oh, like, can I just get a clarification? I'm not sure what that means. Because really they're there to help with the work. And if they're not, sure what you're talking about, then that can lead to some barriers. So creating a safe and supportive environment for the parent partner to share their input and experiences. It can be pretty intimidating coming into, a room with all of these experts, and the parent partner might feel like, their opinion isn't as valuable. So it's really important to create that welcoming environment. Also allowing, having that safe and supportive environment will allow the parent partner to also share negative feedback, because they might feel like, they don't want to make anyone angry. They might be nervous to share, but it's really important to get all the feedback, both positive and negative. And certainly, in the perinatal world, some of those experiences can be really traumatic for people. So having the parent partner feel comfortable sharing their stories and sharing their feedback. Making the meetings as accommodating as possible. So again, you might have your whole team that's already there at your organization working, or they're very familiar with whatever virtual platform you're using. So having free parking or transit reimbursement. Allowing for children at meetings. This was the biggest one for me. If I couldn't have brought my babies to my meetings, I definitely would not have been able to be involved in parent partner work. And then so ensuring any the virtual platform that you're using or the in-person meeting location. I think we all know some organizations you go in and it's a bit of a maze. So I always really appreciate it when, there was a map included in my welcome packet saying, this is the room we're going to be meeting at, because this is, the parent partner might be the only one coming from the outside. So you really want to make sure that they're feeling welcome. So some of the benefits, so they provide a non-medical perspective. So when you're in it every day, there's some things, that you just maybe take for granted or you don't really think about a certain way. So it's really great to get that outside perspective. They can identify gaps in care. Diverse experience can lead to more innovative ideas and can lead to more improved outcomes in the patient-family experience, which is ultimately what I think everyone would like. Some things about recruitment. So if you're creating a poster or a flyer or just a document, it's important to state who exactly you're looking for. So for example, if you want someone that's given birth within a certain time frame, like someone 2 years or less, if you're really looking for the birthing parent, or if you're also open to having a partner be the parent partner for your organization. Make sure to include the time commitment and meeting details. So, the frequency of meetings, are the meetings going to be virtual or in person? And, including if there'll be any kind of work in between the meetings, just emails or document review. When I was looking at any positions, it was really important to have those details because, it'll be hard to get people to sign up if they're, unsure if they're even going to be able to commit to it. So make sure you state any of those, incentives that we talked about earlier. If it's a child-friendly environment, if there's free parking, if you even have the budget for remuneration as well is great to share on there. So where you could share it, so you can have it in your waiting rooms or clinical rooms. You can promote it on your website, social media. You can include it in your discharge packet so that, every family at least is seeing that. If you do have a parent partner and you're looking to expand, they can share with their network and reach out. And then also reaching out to any other organizations in your network. So for example, peer support groups can be a great way to reach a lot of families. So just a few other considerations. So we have to look at what communities are not as represented and how can we attract them. So it's important that we look at any barriers that might be stopping someone from joining and how we can break those barriers down, because it's so important to really have diverse voices in our work. So again, the more voices, the better. So it's so great to have, that one parent partner that's on your committee that's really involved, but continue getting as much feedback as you can. So for example, the BCC patient or client surveys, the more feedback, the better from families. And then you can also look at how parent partners could be incorporated in other areas of your organization. So not just BFI work and not necessarily just, on your birthing unit, throughout the whole organization. It can be really valuable to expand that. So a few resources. So the BCC created a parent partner tip sheet, so that's available on the website. There's a wonderful document from Simon Fraser University called Beyond Inclusion, Equity and Public Engagement. It's a really wonderful document that they've created. And there's a great tool from McMaster University called the Public and Patient Engagement Evaluation Tool. And that's available both in English and in French. So here's my contact information. If you wanted to reach out with any comments or questions, feel free.
Thank you so much, Charlotte. And so if you want to stop sharing, and then Michelle Buckner from the Breastfeeding Buddies program is going to speak to us. Just remember to unmute, Michelle.
Okay, just waiting for my laptop to catch up. Okay, thank you for having me here today. My name is Michelle Buckner. I'm the coordinator of the Breastfeeding Buddies program here in Waterloo Region. I've been coordinating the program for about 12 years. My background is a certified social worker. And much like Charlotte, I am also a parent, partner, coach, mentor, and I was a Little HA League leader for about 15 years. So my passion really is about equity and looking at reducing barriers for families to meet their feeding goals. And so through our peer program, we have partnered with 2 of the birthing hospitals in our region. And so I'm just going to share a little bit about what that journey has looked like. Before we start, the Breastfeeding Buddies program is funded by the Kitchener Downtown Community Health Center. We get funding from the Region of Waterloo's Public Health Unit. And then most recently in the last 4 years, a very benevolent funder in Waterloo Region, the Alice Hallman Foundation. It's allowed us to really expand our program. So one of the things that the Breastfeeding Buddies program participated in was the UNICEF compendium on breastfeeding counseling. And one of the things that was a part of that was for us to submit a video with an overarching messaging around our program. So I'm going to share that with you today, and then give you more details about how our partnership with Grand River Hospital and Cambridge Memorial Hospital has been going, and how maybe potentially other places would see that as a way to increase breastfeeding and lactation rates in their region.
Breastfeeding Buddies is a community-based peer support program that has been active in Waterloo Region, Ontario since 2001. Breastfeeding Buddies aims to assist families to meet their breastfeeding goals through feeling connected and supported in their community. With a population of about 617,000, Waterloo Region includes 3 fast-growing urban cities and is surrounded by rural communities. Canada has a universal, publicly funded health system, and the Breastfeeding Buddies program is located within a not-for-profit community health center. In Ontario, families want to breastfeed. Over 91% of mothers initiate breastfeeding in the hospital, but exclusivity and duration rates drop steadily over time, with only 33% of babies receiving exclusive breast milk at 6 months. Breastfeeding Buddies is a large peer support program with 147 volunteers. To become a buddy, a mother must breastfeed for at least 6 months and complete the program's 18-hour World Health Organization peer-based training. Buddies facilitate prenatal breastfeeding courses, and families can be matched by text, phone, or in person before or after their baby is born. The Breastfeeding Buddies community model relies on partnerships to connect with families facing barriers, such as young mothers, refugees, and parents using substances. In our view, breastfeeding rates are indicators of a community's success or failure in supporting families, not the individual failings of mothers. We offer strength-based, non-judgmental education and advocacy that aims to boost personal self-efficacy and informed decision-making. To grow and sustain a robust volunteer program, we have learned that developing mother-friendly volunteer opportunities that are flexible and include funding for childcare, food, and transportation is very important. We have also learned that building a culture of mutual respect between peer support and community-based leadership means more inclusive support. By using an evidence-informed model of training, peer breastfeeding volunteers are seen as capable and as credible sources of breastfeeding support. As a community leader in normalizing breastfeeding, the Breastfeeding Buddies program works within systems to make change and strongly believes peer breastfeeding support is essential in helping families reach their breastfeeding goals and ultimately creating a healthy, vibrant breastfeeding culture.
So one of the first partnerships that I was going to share with you about was the Cambridge Memorial Hospital Bedside Peer Support Program. So prior to COVID in 2008, we collaborated with the hospital when they did a assessment and realized that their supplementation, non-medical supplementation rates, as well as exclusivity rates on discharge were low. And so this was one of the strategies that they put into place to see if they could change that. So our trained peer volunteers received extra training on scope of practice, infection control, and team communication skills before they were on board. This onboarding process was quite lengthy in that, all of the, even pre-COVID, all their vaccine records needed to be up to date. They had to do on-site training with the hospital and meet the staff on the ward. So one of the goals for our volunteers on ward was we wanted to reach all families and babies who were receiving any amount of human milk, that they would be visited by one of the peers. The interesting component to this that we learned through our journey partnering with Cambridge Memorial Hospital was there sometimes was the perception that maybe a parent that had given birth to their second or third child wouldn't necessarily need support, or that if supplementation was already in place, that also meant that they wouldn't need a peer to visit them. But in fact, what we found was when we went into the rooms of each parent that was giving any amount of human milk to their baby, the questions and the support was often really quickly and well utilized. Our goals when we were in the room with parents was to share information on normal infant feeding behaviors. Really what to expect in those first 48 hours. Is it normal for your baby to maybe initially be a little less interested in nursing and then all of a sudden become ravenous hungry and people doubt their supply in those moments? We talked a lot about hand expression and skin to skin to increase confidence. One of the things that peers did bedside was used really tangible teaching manipulatives where we would have things like containers that would show how much content a newborn baby could handle and what a normal amount of colostrum looked like from hand expressing. So they could really normalize what to expect right away and to eventually and hopefully decrease those unnecessary supplementation rates. The other thing that our bedside program provided was transitional breastfeeding and chest feeding support on discharge. So the whole process when we went into the hospital was it went through ethics committee as well as the nursing union. We really wanted this to be seen as a collaborative approach. Peers were trained about what their scope was. This was not about taking a job away from somebody, but rather working alongside the nursing team. We had amazing results. The nurses were extremely happy to have us there. And likewise, we were happy to be there. And a nurse would often identify, this family needs just a little bit of extra support to get breastfeeding off the ground, but I have 3 other families that I need to discharge this morning. And so this is where that perfect kind of relationship worked, where we would go in and provide that little bit of extra confidence building and emotional support and teaching around what is it going to look like. And so this was also applicable to a lot of our babies that we saw in the NICU, as well as on the pediatric floor. By the end of our time visiting with families, then we were also pulled into their Billy clinic because they found a lot of people that maybe didn't see us on their visit when they gave birth would see us when they could come to the Billy clinic. And then lastly, one of the most important components was we saw this as a transition from hospital to home to community breastfeeding support. And so each parent and baby dyad was offered a peer match before they discharged. And that would be somebody that they could connect with as soon as they got home, to talk to ask questions, and just to, again, really normalize what's going on for them and to ultimately help them meet their nursing and their feeding goals. So the uptake on our peer matches on discharge was about 90%. And so this was a very effective way at increasing our program numbers, as well as collaborating with the hospital and making sure that families knew where to go for help when they were out of the hospital, but maybe still having questions. So the other program that we have been working on is with the Grand River Hospital. So they gifted us or donated 11 hospital grade pumps to our program. They didn't have the capacity to start a loaning program, but they knew that there was a need in the community. So our program really was geared towards addressing financial barriers for families to access pumps. So these might have been families that had a baby that was in the NICU there. Maybe there were other extenuating circumstances like child protection, or the mother was ill. And so we wanted all babies to be able to receive human milk. And this was one of the goals of this collaborative effort. So the hospital staff, as well as their social work team, are the ones that we get the majority of our referrals from. We also have community partner agencies in Waterloo Region that support families that experience the social determinants of health that make referrals to us for the pump loaning program. And it was very, very successful, and it still is very successful. We aren't actually able to keep up with the demand for this, but we have a few credentials or criteria that we base this on. And so that is that they do need to do an intake form. We base it as a 30-day loan. Our Breastfeeding Buddies staff do check-ins with the families to see how things are going if they have any questions. And we also do offer an initial support appointment in order to review this milk making guide that I wrote about when you're transitioning from pumping to the breast. What does skin to skin do to help with your supply, hand expression, storage, all those things that a parent who might be really overwhelmed with having to pump when that wasn't part of their plan, how they can build that self-efficacy as well. So each family that received the pump, again, was also offered the match to be supported by a peer from our program who had lived experience with either a preemie, pumping, or building their own milk supply. This is ongoing with Grand River, and we have really benefited from, again, the community to the hospital to home to community support. So a lot of these families on discharge maybe were leaving their babies at the hospital and the parent wasn't there any longer. And the social worker and the administration team and the nurses have, provided quite a bit of feedback to say that this has been what's alleviated a lot of strain and stress on the parents when they know that they want to provide human milk for their baby, but things didn't go the way that they had planned. So that was a very quick version of our 2 partnerships with our 2 local hospitals. I'm very happy to connect with people if this is something that interests you or you have more questions about it. So we have a very active Facebook group, Instagram account, and our website. The milk making guide is on our website. So we're happy to share that as long as the integrity of the document isn't changed. And this is my email, so if anybody would like to connect afterwards.
Thank you so much, Michelle. If you want to stop sharing, and then we will have Shannon present.
Okay. Okay, hello everybody. My name is Shannon McLennon. I'm a lactation consultant, currently employed part-time in Delhi at the Norfolk Family Health Team, as well as in private practice. My services are called Mama's Manna, but I'm going to talk with you today about the Best Start Resources toolkit that I basically used to start the Breastfeeding Bestie program at my former place of employment. I got my beginnings as a peer support mother in a group, and then became a La Leche lead leader and retired after 17 years as a leader. Okay, so I just wanted to give just a brief history of what we were going. And I also want to acknowledge Michelle Buckner, because I called her many times as I was beginning to develop this program. And I just want to thank you so much in advance, Michelle, because you were a great support. And we can't do this work alone. And so I just really appreciate the mentorship and the support you gave me during this time. So I got the idea for the peer mentor program sort of when I was watching one of the moms in my breastfeeding group at my previous place of employment. And she was just like rocking it and supporting these other moms and just like saying all the right things. And so she really inspired me to want to get this going. And at the time I was only working part-time. So it was pretty challenging. But in 2016, they developed the toolkit. And I was able to do the training with Michelle and Teresa. And I think that was it, right, Michelle? Right. Okay. And I just want to say, like, the toolkit was so amazing and so thorough. And the training was great because they kind of took us through as we would be teaching sort of each module. So that was really helpful. So in 2017, I did my first training session, and out of that came 4 besties. And so as a group, we agreed to call the program the Breastfeeding Bestie program. And it was really important to me from the beginning to really let this group know that this is not my program, that this is our program, and we're going to develop it together. So in 2019, I did another training in person, and I got 8 besties out of that. And as of 2019, the program was up and running, and we had 10 to 12 active besties. Life changes. People might have been, going to do other things. And it was housed out of the Black Creek Community Health Center. To my knowledge, I do not believe that this program is still going there, but it did begin out of Black Creek Community Health Center. So sort of the besties, right, where they were trained community volunteers and have breastfed themselves. They were actually all previous clients of mine that really loved attending the breastfeeding support group that typically saw, 22 mothers each month at this breastfeeding support group. And they're accessible by phone, email, or text. We did talk about them having the opportunity to meet people in the community, but they knew that they were not allowed to go to their bestie's house at all. And so they were knowledgeable already about breastfeeding challenges because they had breastfed themselves and had worked through some serious challenges, you know, sort of individually. And we worked together. So they knew that they could contact me anytime, you know, to ask questions or whatever, or they could refer the bestie back to the LC at any time. And they were also able to provide community resources for families. So in that particular area, I did provide all the resources that they would need to sort of help families in the GTA. So as I mentioned, we did use this toolkit. To be perfectly honest, I did not need to go outside of this toolkit at all. It was organized very well for the facilitator and then organized very well for the participants. So it was really great. If I was to show you my toolkit now, it's very well loved. I've got, you know, pages sectioned off. And so the 3 cohorts that I mentioned, first I did 2 Saturdays. So I was, again, it was a nonprofit CHC. So lots of budget for snack and childcare, because just like I think Charlotte mentioned, it was really important that these trainings were facilitated in a way that babes in arms and small children could come, because some of these moms are single parents as well. So you really have to look at, you know, who are your participants and what do you need to provide in order to reduce barriers for them to become peer volunteers. And then I did another one sort of in the evening for, you know, 6 weeks, 2.5 hours each. Again, snack childcare was huge, especially if it was around dinner. I would make sure that there was sort of dinner stuff. And we had a great parent helper. She got paid, but she was amazing. And she would come early and help me and set up and also facilitate childcare. So I'll just sort of go through what I did first. So first thing first, I went through the toolkit and I picked out and I tailored it to my audience and the community and the participants that were in the training. Okay. The other thing at this point I want to mention about the toolkit, it's really well represented. So all different types of families are represented in this toolkit. And I think we can all agree that that is pretty important to the work that we do. The next thing I did was I sort of developed the consents, right? So based on the criteria that I developed for the participants, the description of the training and how participants could benefit from the program. I then sort of did to those interested, because what I would do is at the group, I would sort of like mention it a few months or a couple months beforehand, letting people know that I was, you know, going to be facilitating a training. And so just sort of planting the seed, getting people used to the idea and if they were interested. And so I would do an information session where we would go over, you know, time commitment, duration of, you know, like the meetings, right? I had monthly meetings. So we went through all of that. And then what I did was I created my planned activities and content for each module separately. So I just took like a big white letter envelope and I wrote module 1, module 2, and then each class or each module I was moving on to, I already had like a pre-made package of what I was going to be doing for that module. So I need to be very organized. And so this is how I organize. Again, you all might do it differently, but I'm just sharing sort of what helped me. And also, how are you going to supply your participants with the resource guide? So obviously when we were in person and I had the budget, I was able to buy binders from the dollar store and I printed the resource guide for the participants. Then they always had that to refer back to. And that was an important piece too, in that you don't have to just like come up with the answer and guess, like you have this resource guide. And I kept referring back to that resource guide, like this is your guide. This is what you can use when you're talking with moms, right? When I did it virtually, obviously I sent it to them electronically. If they wanted to print it off, they could. but that was there for them to sort of follow along, okay? Also, where will your training be facilitated? So at the CHC, obviously, we have community space, and so that was really easy. And we also had a separate room for childcare for older children if need be. The other thing you want to keep in mind is that, you know, your participants are gonna come with some soft and hard skills already. So for example, if you have, you know, a mom who is, you know, a social worker, you're probably, you know, she doesn't need a lot of focus maybe on the counseling aspect and that piece, but she might need a lot of information on the marketing of breast milk substitutes and, you know, the WHO code and how to look for, you know, contradicting information and that. So I also had one of my peer volunteers who had her own business. She was great with Excel spreadsheets, and she agreed to do the data for the program. So they're going to come with skills, use them. And typically they want to help. Although we know with volunteers, you do typically get like that core group, right? Who do a lot of the work, but they're going to come with skills. And so really knowing sort of how to balance the information piece and also, you know, the counseling piece in terms of your role as a peer volunteer. And I engaged peer volunteers to develop the program. So there's where our monthly meetings came in. We developed a video. How are we going to promote? And so it was really important that they were always included. It was a collaboration, right, in what we did. And like I said, we had monthly meetings, and they had to commit to 8 meetings per year, because you can't really do you can't really come to 2 meetings a year and like be engaging in the program or whatever. So that was one thing that I did implement, that you did have to attend 8 meetings per year. So the other thing we did was we developed key messages. You know, one thing I learned is, and we did it as a group, like with the volunteers. And so we really, what were the values of our program, given where we were in the world? And I think that's a really great place to start, because you want to know what your values are. And we know that in health anyway, key messages are huge. And so we developed key messages. And so I'll just, you know, give you a second to sort of, you know, read those. We had peer volunteers from all over the world, you know, Muslim, Africans, Caribbeans, Italian. So it was really important to us that the community of Black Creek was well represented with our peer volunteers. And so that was actually a really, really fun project to do with them. To really develop our values as a group was phenomenal. And so we know why these programs are effective, right? It's emotional and practical support between 2 people who share a common experience. You know, the supporter has lived through similar experiences and then becomes trained to support others. And so they get to bring that shared experience into a more formal context, I guess, and sharing and helping other moms. So the benefits of the peer support: improved mental health, improved self-esteem, improved breastfeeding duration, right, and positive connection. We know all of that. And then some, so then sort of this is how the program worked. The person submitted that they completed a form, that they were interested in the peer volunteer or the peer bestie program. I then matched, so I would contact the peer volunteer, send them the information about the mom, non-identifying, right? And then connect them. And so the peer volunteers knew what their role was once the connection was made. So for example, the instruction really was, you need to connect with them either by phone or by text within 24 hours of getting this match. So they knew what their responsibilities were once they got connected. And so these are just some videos we, so if you would I don't know if this has been taken down yet on the Black Creek website, but if you'd like to take a look at this video that one of my peer volunteers put together because she had expertise in creating videos. Please feel free to go to the website and watch the video. It's really fantastic. And we have peer volunteers actually speaking in their native tongue, talking about the best program. Oh, pause. So anyway, I tried to be as quick as possible. If you would like more information or to pick my brain about what we did, I believe that this program would have become just as great as the Breastfeeding Buddies program had it been given the time. But please do reach out if you'd like. And I'd also like to give credit to this presentation, who was a dietetics student who came and did a placement with me. Can you imagine a dietetics student? And one of her responsibilities was to create a promotional video for the best Breastfeeding Bestie program. So credits to Tia Tucci for this presentation. Thank you everybody for listening, and I'll stop sharing.
Thank you so much, Shannon and Michelle and Charlotte. We don't really have any time for questions right now. Putting them in the chat box. Certainly the speakers can then answer them. And if you have any questions, please feel free to connect with the speakers. And I'll put their email addresses up on the screen at the end. Okay, so I'm going to just stop that for now.